I would like to thank you very much for this opportunity of presenting to you a new perspective about the immunotherapy of sepsis and, as a matter of fact, of novel strategies on how to improve patient management. And with this, I would like to give you an overview of what the future in the way we are seeing things is about. With this in mind, I would like, first of all, to present my conflict of interest disclosure for this presentation, and then I would like to speak briefly about our main challenge for the future, which is the heterogeneity of the patients. So let's imagine that during the COVID-19 era, we were about to do consultation in the ICU, and the first patient we come across is a male of 56 years who has vascular hypertension as comorbidity. This patient has a remarkable laboratory finding. He has extremely increased values of C-reactive protein, which are followed by extremely increased values and concentrations of circulating ferritin. However, if you look of what the patient is getting, he's fully consistent, of course, with the guidelines as this is anticipated. However, this patient who has a profile which is dominated by increased CRP and sky-high ferritin is probably getting exactly the same treatment as the next patient who is older than the first patient with no comorbidities. However, what is striking is that although both of these patients, they have very large infiltrates in chest-history, they are in need of mechanical ventilation because of ARDS. They differ greatly in their laboratory values just because the second patient has a very lower CRP values, almost 30 times lower. And if you compare them with the third patient, who's relatively young, he's male of 56, but with a lot of comorbidities, heart failure, chronic heart disease, COPD, but who has profound lymphocytopenia, who has CRP increase at levels similar to the first one, and who has an increase of ferritin, but not that much, but very prevailing D-dimers. So what's the difference between these three patients? These patients, they look alike, but they have different mechanisms of their disease. In other terms, if we need to generate efficient treatment for the patients, we need to deliver precision treatment. And for this, in order to validate that, we need to fully adhere to what the FDA and what the larger regulatory are suggests. So, if we want to do a randomized clinical trials on precision therapeutics, this needs to be guided by biomarkers. But the biomarker has to meet certain characteristics. The biomarker should be informative on the degrees of application of a certain pathway, which has to be then treatmental for outcome. And there should be an available drug which may modulate the pathway. And we need to start treatment immediately based on the existing alteration of the concentrations of the biomarker, irrespective of clinical signs. So, first of all, I'd like to tell you that this may, yes, be the case, may work in the case of a severe infection. And I'm very proud to present you the first precision immunostrategy for severe infections, which has ever been approved so far. It has been approved by the European Medicines Agency on the 16th of December 2021 for the management of COVID-19. What is the idea? The idea is that we know very well that the virus is binding to the ACE2, which functions as a receptor on lung epithelium. With this in mind, the virus is endocytosed. There is a rapid viral replication inside the epithelial cells, and as a result of that, the cell disrupts with the release of danger-associated molecular molecules. Which are the main downs? It's IL-1 alpha and also calprotectin, which stimulates the production of IL-1 beta. both IL-1 alpha and IL-1 beta, they stimulate IL-1 receptor on the cell membrane of the immune cell, which leads to inflammation. And the cell tries to protect itself by an endogenous antagonist, which binds on the receptor so that the effect of IL-1 alpha and IL-1 beta is attenuated. With this in mind, we decided to develop a strategy which relies on a biomarker, which when increased, the name of the biomarker is SUPAR, informs that the patient is under attack of IL-1 alpha and IL-1 beta. We speak about patients who are not yet critically ill, but they are admitted at hospital. They are in need of oxygen, either by nasal prongs or oxygen mask or high flow oxygen. And we need to prevent the further invasion of the host by the exaggerated IL-1 pathway. And how we do that? By administering anakinra, which is a recombinant human receptor antagonist, which is active and blocks the action of both IL-1 alpha and alpha. So look what the FDA has proved. That all patients with radiologically documented pneumonia in need of oxygen, either low or high flow, with SUPAR 6 or more. SUPAR is the acronym standing for soluble urokinase plus minogen activated receptor. I repeat, it demonstrates that the patient is under the attack of the IL-1 pathway. And why that? Because there was a phase 2 trial showing a 70% overall benefit in the phase 2 program and 64% in the phase 3. And if you ask yourselves, what do we have so far for COVID-19? We have several drugs, not many of them. And what is the overall efficacy? It is ranging between 15% and 20%. Why it is not 70 or 64% as it is for the case of anakinra? Just because there is no mentality on the precision pathway. So the question comes, can we repeat that for sepsis? You know that in the past, we had a lot, particularly 30 years ago, a lot of randomized clinical trials which showed no benefit for the patient just because they had the concept that all patients with sepsis needs to be treated with the available drug. But look what happened with the randomized clinical trial of administering intravenous anakinra for the management of severe sepsis. The trial took place indeed 30 years ago. But as the time went on, we realized that there is an entity which we call the macrophage activation cell. What are the characteristics of this entity? The patients, they should have in parallel hepatobiliary dysfunction with increased bilirubin and acute coagulopathy. So you see there that once this knowledge was available, a post-hoc analysis of the chart took place. And then all of a sudden, we have 4 strata of patients. In the upper part of the survival curves, we have patients with no evidence of macrophage activations, no impact of anakinra treatment. But you see that in the lower in dashed line survival curve are those patients who received placebo, but who were suffering from both hepatobiliary dysfunction and DIC, and in them, the overall death rate was 60%. But exactly above the survival line, there is the solid survival line of patients with these 2 clinical entities who were treated with anakinra, and there the mortality rate went down to 30. The survival rate was increased. The mortality went down to 35%, and that was statistically significant. So the question comes, what is this macrophage activation cell? So TLR4 is activated particularly by LPS. This leads to activation of NF-kappa beta and the production of pro-inflammatory cytokines and also of IL-1 beta. But it may be the case that viruses which are reactivated in the septic host, they stimulate TLR9, and this in turn leads to further production of IL-1 beta. So IL-1 beta in an autocrine way, it stimulates the IL-1 receptor, and this leads to, and through an autoinflammatory loop, to further production of IL-1 beta. And what we see there is a release of soluble CD163. This IL-1 beta stimulates the liver for further production of ferritin by the decrease of production of fibrinogen. And we call this entity a macrophage activation-like syndrome, which is different than the primary HLH and also different from the CAR T cells associated cytokine release storm. It's not driven by interferon gamma, and hemophagocytosis is seldom present. But this entity is an independent driver for early mortality the first 10 days, even in the presence of ARDS, or in the presence of acute kidney injury, or in the presence of circular shock. How can we early recognize and easily recognize that our patient is suffering from this macrophage activation-like syndrome? We are in need of a biomarker, and we developed as a biomarker using data coming from the Hellenic Registry of Sepsis, ferritin, but look at the concentrations. The cutoff that we suggest is more than 4,420 nanograms per ml, and we split actually our patients into cohorts. In the first cohort, patients with such high concentration, they ended up with a mortality after 20 days of 66.7%, but also in the second cohort, we see that fully repeatable. And then we studied an independent cohort coming from Sweden, and again, we have a validation of the finding. And as a matter of fact, such high concentrations of ferritin, they have specificity of 97.1% and negative predictive value of 98% for the classification of the patients into macrophage activation links. We felt very happy when we realized that a recent publication of the PROCESS trial, using again as a classifier of macrophage activation syndrome on 1,341 patients, defined that 6% of these patients, they have macrophage activation syndrome. And again, you see that this leads to early mortality the first 10 days, but also what is the key diagnostic of the situation? It is ferritin. And also with ferritin, the soluble CD163, which is a marker of activation of tissue macrophages, is increased. So, we spoke about hyperinflammation. We spoke about cytokines. We spoke about macrophage activation syndrome, but could it be the case that there is another edge of this sort? In other terms, could we have patients whose peripheral blood mononuclear cells, instead of being hyperactivated, could be exhausted? Look here the example. These are the PBMCs of the patients. You see that the first days when you stimulate them with LPS, they barely produce anything. And we split these cells into blue, which are the cells isolated from survivals, into red, cells isolated from non-survivors. And you see that all of a sudden, that after 48 hours, some cells, they wake up. And these are the cells of the survivors, which will use a lot of TNF. In other terms, the outcome is associated with the ability to escape sepsis-induced immunoparalysis, which means failure to engulf the bacteria and risk for secondary infections. So the question is, can we indeed develop tools, and can we prospectively validate the tools that we have? We did that in a phase 2 study with the heparin provider. And actually, we enrolled in the study patients with lung infections, either community-acquired or hospital-acquired, or patients with primary bacteremia. And we used classifiers in order to discriminate and classify patients into macrophage activation syndrome, patients with immunoparalysis, patients with intermediate stage, trying to investigate if this classification reflects final patient disposition. And in the few patients who were macrophage activation syndrome, we tested in a double-blind randomized approach the impact of anakinra. So, which are our classification tools? Ferritin, more than 4,420 signifies macrophage activation syndrome. But if ferritin is less than, and in parallel, the patient has less than 5,000 receptors of H and ADR on CD14, both sides, we call that sepsis-induced immunoparalysis. And our intervention in macrophage activation syndrome was in a double-blind randomized approach, either anakinra or placebo. So look how immunoclassification drives outcome. Patients in red are those with macrophage activation syndrome. They have the worst outcome. As a matter of fact, it is roughly, in our study, 20% of the patients. Only 20% stay alive after 20 days. Above them are patients with immunoparalysis. It's roughly 42.9% of the entire cohort. Only 40% remains alive after 20 days. And finally, those with intermediate state who had the best prognosis. And all of a sudden, we had some traces of hope. At the end of the 7-day treatment with anakinra, you see that there is a decrease of SOFA score of patients receiving therapy compared to patients receiving placebo. So what we suggest that we need to do? In patients with macrophage activation syndrome in red, we need to give anakinra. In patients with immunoparalysis in blue, we need to stimulate, to wake up the immune system. How? By giving recombinant interferon gamma. And there is a randomized double-blind trial which is taking place nowadays in Germany, Greece, in Italy, in the Netherlands, in Romania, in Switzerland, enrolling patients with lung infection or primary bacteremia, with sepsis defined according to sepsis 3 definitions, with macrophage activation syndrome or immunoparalysis. And then the first 72 hours from sepsis onset, patients are randomized in the precision immunotherapy group. And these patients, they get 2 interventions. One intravenous, which is anakinra in case of macrophage activation syndrome. One sub-Q, which is recombinant interferon gamma in case of immunoparalysis. And also the patients, they get the DAM intervention. Whereas if the patients are randomized to treatment with placebo plus standard of care, they receive 2 DAM interventions. And then we change the primary endpoint, which is not anymore mortality, but change of mean SOFA score by day 9. Is this trial feasible? Is the study enrolling patients? The answer is yes. Look at our progress. By the end of April 2023, 439 patients have been screened. 167 patients have been enrolled, the majority with sepsis-induced immunoparalysis. We are really confident that this study will give us new tools, new knowledge, new information about sepsis immunoclassification, and can drive the future hope for sepsis management. Thank you very much for your attention.